Here are the definitions of the key terms found in Chapter 6, Maxillomandibular Relations, from the provided textbook pages. Key definitions. Joint and anatomical structures. Temporomandibular joint, TMJ, the articulation between the temporal bone and the mandible. It is a bilateral diarthrodial and bilateral gynlymoid joint. The articulation of the condylar process of the mandible and the intra-articular disc with the mandibular fossa of the squamous portion of the temporal bone. A diarthrodial, sliding hinge, gynlimous, joint. Movement in the upper joint compartment is mostly translational, whereas that in the lower joint compartment is mostly rotational. The joint connects the mandibular condyle to the articular fossa of the temporal bone with the temporomandibular disc interposed, GPT-8. Glenoid fossa, the concavity in the temporal bone by the zygomatic arch that receives the mandibular condyle, GPT-8. Articular capsule, the fibrous ligament that encloses a joint and limits its motion. It is lined with the synovial membrane, GPT-8. Articular disc, a ring of fibrocartilage that separates the articular surfaces of a joint, GPT-8. Jaw relations and positions. Centric relation, CR, the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with the complex in the anterior superior position against the slopes of the articular eminences. This position is independent of tooth contact. This position is clinically discernible when the mandible is directed superiorly and anteriorly. It is restricted to a purely rotary movement about the transverse horizontal axis, GPT-5. Maximal intercuspal position, MIP, the complete intercuspation of the opposing teeth independent of condylar position, sometimes referred to as the best fit of the teeth regardless of the condylar position, called also maximal intercuspation, GPT-8. Eccentric relation, any relationship of the mandible to the maxilla other than the CR, GPT-8. Physiologic rest position, the postural position of the mandible when an individual is resting comfortably in an upright position and the associated muscles are in a state of minimal contractual activity, GPT-8. Maxillomandibular relationship, any spatial relationship of the maxillae to the mandible, any one of the infinite relationships of the mandible to the maxillae, GPT-8. Maxillomandibular relationship record, a registration of any positional relationship of the mandible relative to the maxillae, GPT-8. Measurements and distances. Vertical dimension at rest, the length of the face when the mandible is in the rest position, GPT-8. Vertical dimension of occlusion, occlusal vertical dimension, the length of the face when the teeth are in contact in maximal intercuspal position, maximal intercuspation. Interclusal distance, the distance between the occluding surfaces of the maxillary and mandibular teeth when the mandible is in a specified position, GPT-8. Interclusal rest space, freeway space, the distance between the occluding surfaces of the maxillary and mandibular teeth when the mandible is in its physiologic rest position, GPT-8. Campus line, ala tragus line, the line running from the inferior border of the ala of the nose to some defined point on the tragus of the ear, usually considered to be the tip of the tragus, GPT-8. Mandibular movements and translations. Excursional movement, movement occurring when the mandible moves away from maximum intercuspation, GPT-8. Transverse horizontal axis, an imaginary line around which the mandible may rotate within the sagittal plane, GPT-8, also called the hinge axis, previously. Christensen's phenomenon, space that occurs between opposing occlusal surfaces during mandibular protrusion, GPT-8. Bennett angle, the angle formed between the sagittal plane and the average path of the advancing condyle as viewed in the horizontal plane during lateral mandibular movements, GPT-8. Early mandibular translation, early side shift, the translatory portion of lateral movement in which the greatest portion occurs early in the forward movement of the non-working side condyle as it leaves centric relation, CR, GPT-8. Progressive mandibular translation, progressive side shift, the translatory portion of mandibular movement as viewed in a specific body plane that occurs at a rate or amount that is directly proportional to the forward movement of the non-working condyle, GPT-8. Immediate mandibular lateral translation, the translatory portion of lateral movement in which the non-working side condyle moves essentially straight and medially as it leaves the CR position, GPT-8. Envelope of motion, the three-dimensional space circumscribed by mandibular border movements within which all unstrained mandibular movements occur, GPT-8. Central bearing terminology. Central bearing tracing device, a device that provides a central point of bearing or support between the maxillary and mandibular dental arches. It consists of a contacting point that is attached to one dental arch and a plate attached to the opposing dental arch. The plate provides the surface on which the bearing point rests or moves and on which the tracing of the mandibular movement is recorded, GPT-8. Central bearing point, the contact point of a central bearing device, GPT-4. Central bearing tracing, the pattern obtained on the horizontal plate used with a central bearing tracing device. Here are the key definitions and concepts from pages 103 through 107 of Chapter 6, Maxillomandibular Relations. 1. Mandibular movements and guidance angles. Christensen's phenomenon. In a natural dentition, edge-to-edge protrusive contact creates a gap between the posterior teeth. In complete dentures, this gap must be eliminated by maintaining simultaneous posterior tooth contact to stabilize the denture during protrusive movement. Protrusive condylar guidance angle, inclination, the angle formed by the average path of the advancing condyle with the frontal plane during protrusion. It is determined using protrusive records. Retrusive movement, movement of the mandible towards the posterior, GPT-8. Working condyle, rotating condyle, the condyle on the side to which the mandible moves during lateral excursion. Non-working condyle, orbiting condyle, the condyle on the side opposite to the direction of mandibular movement. Mediotrusion, the forward, downward, and inward movement of the non-working side condyle. Bennett angle, lateral condylar guidance angle, the angle formed between the average path of the advancing non-working condyle and the sagittal plane during lateral movement. Bennett movement, laterotrusive, mandibular lateral translation, the bodily lateral movement of the working side condyle. It can be classified by timing as immediate side shift, occurs at the very beginning of lateral movement. Early side shift, takes place early in the movement. Progressive side shift, distributed evenly throughout the movement. 2. Border movements and envelope of motion. Border movements, mandibular movements at the extreme limits dictated by anatomic structures, bones, ligaments, muscles, as viewed in a given plane, GPT-8. Sagittal border movements, traces movements from centric occlusion, CO, right arrow maximal protrusion, F, right arrow maximal mouth opening, E, right arrow closing along the posterior hinge path, BCO. Horizontal border movements, traces movements from CR to extreme right and left lateral limits, then to maximal protrusion, forms the Gothic arch tracing. Frontal border movements, traces movements from CR to extreme right and left lateral limits to maximal opening and back. Envelope of motion, Possel's envelope, the three-dimensional space circumscribed by mandibular border movements within which all unstrained movements occur, GPT-8. 3. Functional and parafunctional movements. Functional movements, movements associated with normal physiology such as chewing, swallowing, speaking, yawning, and respiration. Chewing cycle phases, Murphy, preparatory phase, mandible deviates toward the chewing side, tongue positions food. Food contact phase, sensory receptors trigger on food contact. Crushing phase, rapid initial movement slowing as food is crushed. Phase of tooth contact, reflex neuromuscular adjustments occur. Grinding phase, occlusal tables guide grinding movements. Centric occlusion phase, cusp slice food, returning to terminal position before next cycle. Parafunctional movements, sustained, non-functional activities resulting from increased muscle activity, such as bruxism, clenching, and habits, e.g., pipe smoking, pencil biting. 4. Muscles involved in mandibular movements. Masseter, closing and retrusion. Temporalis, elevation and retrusion. Medial pterygoid, closing and lateral movements. Lateral pterygoid, opening, protrusion, and lateral movements. Suprahyoid group, depresses the mandible, opens mouth, assisted by the infrahyoid group. 5. Classification of maxillomandibular relations. Orientation, orientational, relations. Establish the spatial relationship of the maxilla to the cranial base, skull in three reference planes. Vertical relations, establish the degree of jaw separation or vertical height of the face, vertical relation at rest. Vertical relation in occlusion, occlusal vertical dimension. Horizontal relations, establish antero-posterior and side-to-side relationships, centric relation, CR, eccentric relations, protrusive and lateral. Here are the key definitions, components, and procedures covering pages 108 through 113 of Chapter 6, Maxillomandibular Relations. 1. Key definitions. Face bow. A caliper-like instrument used to record the spatial relationship of the maxillary arch to some anatomic reference point or points and then transfer this relationship to an articulator. It orients the dental cast in the same relationship to the opening axis of the articulator. Customarily, the anatomic references are the mandibular condyles, transverse horizontal axis, and one other selected anterior point, also called hinge bow, GPT-8. Arbitrary face bow. A device used to relate the maxillary cast to the condylar elements of an articulator using average anatomic landmarks to estimate the position of the transverse horizontal axis on the face, GPT-8. Also called average axis face bow. Kinematic face bow. A face bow with adjustable caliper ends used to locate the transverse horizontal axis of the mandible, GPT-8. It locates the true, exact, center of condylar rotation or transverse horizontal axis. 2. Classification of face bows. A. Arbitrary face bows. Determines the approximate center of rotation of the condyle, positions the hinge axis within 5 mm of the true center. Earpiece type, ear bow, uses the external auditory meatus as a reference point to determine the condylar rotation center. The condyles are located at an approximate distance in front of the meatus, compensated for by mounting behind the condylar center on the articulator. Fascia type. The condylar rotation center is arbitrarily marked 13 mm anterior to the middle of the tragus of the ear along the canthopterygial line, from the outer canthus of the eye to the middle of the tragus. B. Kinematic face bows. Locates the exact hinge axis by having the patient execute opening, closing movements in CR, up to 12 mm without translation, until the stylus shows pure rotation rather than translation. Preferred in full mouth reconstruction. 3. Basic parts of a fascia face bow. U-shaped frame, metallic frame to which all other components attach. Extends 2 to 3 inches anterior to the face to avoid contact. Condylar rods. Calibrated metal extensions fitted on either side of the U-frame placed over the condylar center. Bite fork. U-shaped rod attached to the maxillary occlusal rim while recording orientation relation. Locking devices, clamps. Locking clamp for the bite fork. Locking clamp for the orbital pointer pin. Locking screws for the condylar rods. Orbital pointer pin marks the anterior reference point, infraorbital notch, to establish the third point of reference for the horizontal plane. 4. Clinical procedure for recording orientation jaw relation, fascia type, mark reference points. Mark a point 13 mm anterior to the tragus on the canthopterygial line on both sides of the face. Attach bite fork. Mildly heat the bite fork and insert it into the maxillary occlusal rim, approximately 3 mm above the incisal plane and parallel to the occlusal plane. Center the fork with the patient's midline. Position assembly. Place the rim with attached bite fork into the patient's mouth. Slide the U-frame over the stem of the bite fork. Adjust condylar rods. Place the condylar rods over the marked points on the face, ensuring equal calibrations on both sides. Set anterior reference point. Palpate the infraorbital notch and adjust the orbital pointer to this point. Lock apparatus. Tighten all locking screws securely. Remove and transfer. Loosen only the condylar screws, carefully remove the assembly, and prepare it for mounting on the articulator. 5. Articulator programming settings mentioned. Horizontal condylar inclination, set at 40 degrees. Bennett angle, set at 20 degrees. Here are the key definitions, methods, and principles covering pages 114 through 119 of Chapter 6, Maxillomandibular Relations. 1. Indications and use of face bow. Indications: when balanced occlusion is desired. When the vertical dimension is subject to change. Without face bow. If a face bow is not used, the maxillary cast is mounted arbitrarily on the articulator using the occlusal plane as a guide. Studies indicate that failing to use a face bow only leads to minor occlusal errors that can be corrected intraorally upon delivery. 2. Key definitions: vertical relations, vertical jaw relation, vertical dimension. The length of the face as determined by the amount of separation of the jaws under specified conditions. Vertical dimension at rest, VDR, physiologic rest position, the postural position of the mandible when an individual is resting comfortably in an upright position and the associated muscles are in a state of minimal contractual activity, GPT-8. Vertical dimension of occlusion, VDO, occlusal vertical dimension, the length of the face when the teeth are in contact in maximal intercuspal position, MIP. Interclusal rest space, freeway space, the vertical distance between the teeth at rest position. In dentulous individuals, it ranges from 1 to 10 mm, average 2 to 4 mm. 3. Methods of determining vertical dimension at rest, VDR, factors influencing rest position. Patient posture, sitting upright, standing, looking straight ahead. Patient relaxation. Neuromuscular disturbance. Duration, VDR cannot be maintained for long periods. Use of multiple methods to verify. Specific techniques. Facial measurements. 2 points are marked, one on nose tip, one on chin. Distance is measured using dividers, scales, Willis gauge, or decometer. Phonetics. Patient repeats words containing the letter M. Tactile sense. Patient opens wide until strain is felt, then slowly closes until comfortable. Swallowing. Patient licks lips and swallows. Mandible assumes rest position at the end of swallowing. Facial expression. Lips in even contact, skin around eyes, chin relaxed, unobstructed breathing. Willis guide. Distance from pupil of eye to corner of mouth, rima oris, equals distance from anterior nasal spine to lower border of mandible at VDR. 4. Methods of determining vertical dimension of occlusion, VDO, aphysiologic methods. Nisonga's method uses VDR-2 to 4 mm freeway space. Swallowing threshold. Soft wax cone on lower base touches upper rim during swallowing. Phonetics, closest speaking space, Silverman's closest speaking space, minimum 1 to 2 mm clearance between incisal edges during rapid speech, pronouncing S sounds. Pronouncing CH and J brings anterior teeth close without touching. Neuromuscular perception, tactile sense, central bearing device, adjustable screw adjusted until comfortable. PowerPoint, Boo's method, uses a B-meter to measure maximum biting force. Maximum force occurs at VDO or VDR-2 mm. Aesthetics, observation of lip contour, skin tightness, and facial symmetry. B. Mechanical methods. Ridge relations, incisive papilla to mandibular incisors. Distance from incisive papilla to mandibular incisal edge is approximately 4 mm in company. Ridge parallelism. Maxillary and mandibular ridges are nearly parallel with a 5-carat circ posterior opening. Pre-extraction records, profile photographs, life-sized photographs compared with occlusal rims in place. Profile silhouettes, cardboard cutout or wire contoured to the facial profile. Radiographs, cephalometric or condylar radiographs. Articulated casts, measuring intra-arch distance on pre-extraction casts mounted in crossing. Facial tattoo marks, tattoo points placed on upper and lower facial halves prior to extraction. Measurement of former dentures, measuring vertical distance using the patient's old dentures as a reference. Here are the key definitions, principles, and procedures covering pages 120 through 125 of Chapter 6, Maxillomandibular Relations. 1. Effects of altered vertical dimension. A. Increase in vertical dimension. Discomfort alters the oral environment, causing teeth to make contact sooner than expected during automatic chewing movements. Trauma. Frequent, sudden contact causes trauma to denture-bearing areas, particularly under the lower denture. TMJ problems. Continuous tooth contact causes soreness and pain in the TMJ. Bone resorption. Inability of elevator muscles to complete contraction leads to continuous exertion of force, resulting in alveolar bone resorption. Muscular fatigue. Muscle strain from trying to close the mouth completely. Clicking of teeth. Premature contact causes teeth to click during speech, chewing. Facial distortion. Strained expression with elongation of the lower face and inability to comfortably close the lips. Difficulty in swallowing and speech. Inability to achieve lip seal impairs swallowing and phonetics. B. Decrease in vertical dimension. Masticatory inefficiency. Reduced biting force leads to inefficient mastication. Cheek biting. Loss of cheek muscle tone allows flabby cheek tissues to get trapped during chewing. TMJ problems. Mandible must over-protrude to achieve occlusal contact, leading to joint pain and clicking. Facial distortion. Nose appears closer to chin, loss of lip fullness, flabby facial tissue, and an aged appearance. Angular cheilitis. Deep folds formed at the corners of the mouth become bathed in saliva, predisposing them to infection. 2. Horizontal relations and centric relation, CR, definitions. Centric relation, CR, the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with the complex in the anterior superior position against the slopes of the articular eminences. The most retruded physiologic relation of the mandible to the maxilla from which the individual can make lateral movements, GPT-3. Maximal intercuspal position, MIP, complete intercuspation of opposing teeth independent of condylar position. Centric occlusion, CO, occlusion of opposing teeth when the mandible is in crossing. Significance of CR in complete dentures. CR and MIP must coincide. In edentulous patients, loss of periodontal ligament proprioceptors removes the mechanism to avoid deflective contacts. Unaligned MIP causes base displacement and tissue trauma. Reference to transverse horizontal axis serves as the hinge axis around which opening, closing occurs on the articulator. Reproducible position, repeatable over time, making it a reliable reference point. 3. Methods of retruding the mandible. A. Passive methods, patient action, relaxing and closing on back teeth. Touching the posterior roof of the denture with the tongue while closing. Swallowing and closing. Rapidly tapping occlusal rims together. Tilting the head back during closure. B. Active methods, dentist assistance, thumb and forefinger guidance. Dentist places thumb and forefinger on the chin to apply a mild, firm posterior force during closure. Dawson's bimanual palpation. Dentist stands behind the patient, placing fingers along the lower mandibular border and thumbs at the symphysis. An upward force with fingers and downward force with thumbs guides condyles into CR. 4. Methods used to record centric relation. A. Static methods, tentative CR record, records position without functional, exversive movements. Wax occlusal rims. Rims are contoured, guidelines marked, and sealed together using nick and notch method, recommended, V-shaped notches cut in the maxillary rim, molar region, with a nick anterior to the notch. A trough is made in the mandibular rim, filled with zinc oxide eugenol, soft wax, or elastomeric material. Heat or staple pins, not recommended due to distortion, burn risk. Interclusal check records, used at try-in or insertion to verify CR using materials like aluwax. B. Functional, chew-in, methods. Utilizes functional mandibular movements to carve, grind record material. Needle house method, metal balls, styli embedded in maxillary rim carve diamond-shaped tracings into compound on the lower rim during functional excursions. Patterson method, trench in lower rim filled with equal mixture of carborundum paste and plaster. Mayer's method, soft wax used to generate a functional pathway. C. Graphic methods. Tracing mandibular movements on flat plates, Gothic arch tracing, records horizontal movements on a single plane. Pantographic tracing, records movements in all three planes. Here are the key concepts, procedures, and definitions from pages 126 through 132 of Chapter 6, Maxillomandibular Relations. 1. Gothic arch tracing, arrowhead, needle point tracing, a concept and components. Concept: attaching a stylus, pointed writing device, to one occlusal rim and a recording plate to the other. As the mandible executes excursive movements from centric relation to protrusive, right, and left lateral positions, the stylus traces an arrowhead, or Gothic arch, pattern. Central bearing device, placed at the geometric center of the maxillary and mandibular arches to maintain vertical dimension, distribute supporting tissue forces equally, and allow joint condyles to dictate mandibular movement. Types: extraoral tracer, stylus and central bearing plate attached to the maxillary rim, central bearing point and recording plate attached to the mandibular rim. Intraoral tracer. The central bearing device also acts as the tracing device, a single set of devices. B. Indications and contraindications. Indications: broad edentulous ridges, adequate intra-arch space, and patients with a habitual centric position, eliminates bad neuromuscular reflexes. Contraindications: severely resorbed ridges, flabby tissue, reduced intra-arch space, TMJ arthropathy, or abnormal jaw relations. C. Comparison of intraoral versus extraoral traces, Table 6.3, intraoral traces. Extraoral traces. Tracing not visible during tracing, verification of movements, position is not possible. Tracing is visible, movement and position can be verified. Tracings are small, may be difficult to locate apex. Tracings are larger, apex is more discernible. Central bearing and recording devices are placed intraorally. Movement is interrupted by lips and cheeks. Lips and cheeks may interfere as recording device is placed extraorally. Example, Cobalt tracer. Example, height tracer. D. Troubleshooting tracing inaccuracies. Apex absent, round, weak retrusive movement. Patient requires more training. Double arrow point, habitual plus retruded CR or alteration in vertical dimension during tracing. Interrupted Gothic arch, posterior interference at heels during excursions. 2. Pantographic tracings. Pantograph, an instrument used to graphically record mandibular movements in one or more planes, horizontal, sagittal, and frontal, using styli, recording plates or electronic sensors to program a fully adjustable articulator. 3. Eccentric jaw relations. A. Protrusive records. Used to adjust the protrusive, horizontal, condylar guidance inclination of semi and fully adjustable articulators. Methods. Graphic method, Gothic arch, central bearing and recording devices are reseated in the patient's mouth. A mark is placed 5 to 6 mm anterior to the apex along the protrusive line. The patient protrudes until the stylus hits the mark, and quick-setting plaster is injected between the rims. Static method. Soft baseplate wax is placed over mandibular teeth, rims. Patient protrudes 5 to 6 mm and bites down into wax. B. Lateral records. Used to adjust the lateral condylar inclination of the articulator. 2 records required, right and left lateral. Hanau formula. For semi-adjustable articulators unable to accept direct lateral records, the lateral condylar inclination, L, is derived from the horizontal condylar inclination, H. 4. Chapter summary highlights. Satisfactory oral function with complete dentures requires establishing a reproducible mandibular position, maximum intercuspation at centric relation. This relation must be established at the correct vertical dimension to ensure adequate interclusal clearance at rest.